have seen how hyperuricemia, in the presence of certain factors, environmental factors, lead to crystal formation. We have seen why crystals deposit within the joint. Now, another important point to highlight is that crystal deposition does not mean systematically inflammation. Why? For the simple reason that asymptomatic hyperuricemic patients with deposited crystals and they're still asymptomatic. So something must happen so that inflammatory response occur. So what does it actually happen? Inflammation is initiated when a part from the crystal strips and becomes uncoated. This uncoated, stripped portion of the crystal will initiate an inflammatory response. Does this remind you of something that you have already seen? I mean, there is a clinical condition, there is a pathological mechanism that resembles a lot this concept. In myocardial infarction, in athermatous plaques within blood vessels, we have the plaque here, happy plaque, nothing, no inflammation, no clots, nothing. But when it is damaged and uncoated, the clotting process and the inflammation happen. It's the same concept here also. Inflammation does not occur until a part of these crystals, these deposited crystals, strips away and becomes uncoated with pro-inflammatory properties. Now we are going to review briefly the clinical correlations that we have learned up to now from this discussion. Now we are going to think as clinicians. We started with hyperuricemia inflammation. As a clinician, we already know that we are going to order uric acid levels at some point of our workup. Inflammation, so we are going to order some ESR, CRP, complete blood count. We talked about low temperature, low pH. Low temperature told us why the MTP is involved, almost always involved, why gouty flares are self-limited. Low pH told us why at night, why flares happen at night, waking up the patient who was asleep. Told us low pH also told us about some triggers like alcohol consumption. So these are things that we are going to collect in our history. Someone comes in with MTP arthritis. We think about gout. Now we know why we think about why the MTP, why the flare is self-limited, why it happens at night, why after alcohol consumption. We have seen that crystal deposit within joints or kidneys. If someone comes with gouty arthritis, to have more arguments about that, we can find a history of nephrolithiasis. We have always seen why joints are involved. What else? Yes, the last point. We said that inflammation doesn't occur until a part of crystals strips away. The uncoated crystal now has pro-inflammatory characteristics and will initiate inflammation. This has two important clinical correlations. We know that local trauma is a trigger of gouty flare. Local trauma. What does local trauma do? Local trauma will lead to physical release of crystals deposited within the cartilage. Now, and will become encoded and has now the ability to promote inflammation. Also, another important point: acute lowering of synovial urate level will precipitate into gouty flares. Why? By the same mechanism, acute lowering of synovial urate levels. So these were the clinical correlations that we have learned up to now. In the next videos, we're going to talk about the inflammatory response, hyperuricemia, the etiologies, and we're going to briefly discuss epidemiology, clinical presentation, workup, and treatment. That was GOUT.